And if you're joining us from the last session, welcome back to day three of our Critical Access Hospital virtual conference for Stroudwater here. So managing a rural practice requires balancing limited resources, workforce constraints, patient access challenges, and operational efficiency, often all at the same time. Yet many of the operational barriers affecting performance are both identifiable and addressable when organizations have the right visibility into workflows, scheduling, productivity, and practice operations. In this session, Shad Ritchie and Megan Hazelton of Stroudwater will share practical, high-impact operational strategies that rural practice leaders can implement immediately to strengthen clinic performance and improve patient access. Through supporting rural hospitals, provider groups, and ambulatory practices, they've helped organizations evaluate operational bottlenecks, improve provider productivity, and strengthen practice performance in resource-constrained environments. And I just want to make an announcement. We will have time for questions at the end of this presentation. Please post your questions using the Q&A function in Zoom. If you can't see it, it might be under the More button, and it just says, it's a little question mark and says Q&A. And you can do that while the presentation is ongoing, and we'll address them at the end. So let's take it away, Megan and Shad.
All right. Thanks, Keith. We appreciate you. My name is Shad Ritchie. I'm a senior consultant with Stroudwater, and I have a teammate with me. Megan, feel free.
Yep, thanks, Chad. My name is Megan Hazelton. I'm a consultant with Stroudwater, and it's great to be with you all today.
Yeah, so good morning to those that are on the West Coast, or I am on the East Coast. So good afternoon to those that are on the East Coast. Like Keith said, we are going to be talking today about practice management in rural settings. And our goal is to talk about high impact fixes for immediate improvement. So as a previous administrator, education, it was fantastic for me to get theory-based information, but seminars like this and also networking with your people that work in the same setting as you really learn a lot from things like this and then networking. So we appreciate you all being on today and hoping you're having a good conference overall. So with that said, I'm going to go ahead and go to the next slide. So we know that a lot of you all are in the rural communities, and you're going to know a lot of the things that we're going to be talking about today. It's not going to be anything earth-shattering. Our goal is not to be theory-based, but to give you practical information to be able to apply this to your clinics. And so as rural leaders, you all are uber smart, you're experienced and resourceful. So basically, we're going to look at some objectives today. And by the end of this session, we hope that you're going to be able to identify and isolate the operational bottlenecks that are unique to rural practices. We hope that you can implement some scheduling changes if that's something that you all want to do. Look at access for your practices and throughput with optimization strategies. And then finally, apply practical performance framework to monitor provider productivity and clinic efficiency. So that's a lot of verbiage, but we're going to break all that down to be something that's going to be a little bit more clear, and hopefully you can apply that in your clinic. So with that said, we would love to have our first polling question. And this could be a loaded question for those of you that are on the this presentation. So what is the primary operational barrier currently limiting rural clinics' performance, and specifically yours? A, high no-show rate and unfilled scheduling gaps. B, staff shortages. C, low provider productivity or perhaps perceived underutilization. D, patient transportation and geographic access. And finally, E, coding, billing, or revenue cycle. You may all have issues with all of these, but we'd love to get your perspective on the most one that is limiting your rural clinic performance currently?
Great. So yeah, just looking off the results here, it's looking like, all of you are experiencing obviously more than one of these, but primarily a lot of you are experiencing that low provider productivity and perceived underutilization, which, is really common in a lot of our rural clinics. But we'll be diving into that a little bit more today, as well as some of these other challenges that you all are experiencing. So thank you all for participating in that.
Yes, thank you.
Yeah, so before we dive into some of the solutions that we're going to be offering you all today, we just want to take some time to acknowledge something that everyone who's participating in this webinar already knows, and that is that managing a rural clinic is just fundamentally different from managing a clinic in a suburban or an urban market. One of the realities of rural healthcare is that we have fewer resources. Oftentimes, there are fewer layers of support, and just overall a lot less room for error. You're going to experience it when you have a staff member who calls out sick. You're going to be feeling that pressure. Or when a provider leaves you, it's going to take you a lot longer to replace them compared to a more urban setting. And when your workflows break down, there isn't a lot of extra capacity just sitting on the sidelines to absorb those impacts. But at the same time, your rural providers and staff are incredibly resourceful. You're constantly balancing patient care, your staffing challenges, access issues, and the financial pressures that you all are experiencing. So today's session isn't just about spending more money or hiring an army or anything like that to increase your operational efficiency, but it's really about getting more out of the resources that you all already have.
Perfect. So that kind of leads us into some of the other information that we'd love to talk about. So why was 2025, 2026 the year of operations? And I say the word was because we are almost halfway through 2026. Can you believe it? It's hard to believe. But with that said, we've had a lot of regulatory shifts, especially with RHCs and rural health clinics. There's been a lot of regulatory changes, and we're going to talk about that later on in the presentation. But many of you have already seen the productivity floor eliminated and GO 511. We've seen the market shift from post-pandemic patients. So patients are wanting different care in a different way. And so we have to hopefully shift to make that work for patients. And then finally, financial pressure is the biggest one that I think that we all as administrators and former administrators feel each and every day. Rural hospital closure rates are accelerating. So with that said, clinics must demonstrate financial sustainability. A lot of times we hear that practices that are owned by hospitals, they always lose money. Well, that doesn't always have to be the case. So hopefully some of the things we're going to talk about is going to help with the financial pressure component. One of the quotes, though, that I do like to say is the one from Stroudwater Associates. And this is pretty good. It says, the rural clinics that survive the next decade will not be the ones with the best buildings or the biggest budgets. They will be the ones that outperform on operations. And that is going to be so true in not only the finishing of 2026, but in the future. We have to focus on operations to be more efficient.
Yeah, so we want to spend a little bit of time just talking about, where rural practices are actually losing money today. And so when people think about financial challenges in healthcare, we often immediately jump to reimbursement rates, payer mix, staffing shortages, and those are really important factors. But what we see over and over again with the organizations we work with is that many of the biggest financial losses are happening through everyday operational inefficiencies. So it could be an open appointment slots or missed follow-ups, maybe a patient no-shows and just never gets rescheduled. It could also be a provider spending time on administrative tasks instead of seeing patients. And so none of these issues seem significant in isolation, but when they're happening every day across multiple providers, that financial impact becomes substantial. The good news, though, is that these are areas where clinics have much more control than they often realize. And so, as you're looking at these 4 categories on this slide, we really want to encourage you to think about your own organization and which of these is feeling the most familiar to you. So, are you experiencing access as the challenges? Do you have patients waiting weeks for open appointments while schedules still have your open slots? Or are you experiencing provider utilization issues? Are there revenue cycle gaps where your services are being provided but maybe not fully captured or reimbursed? Or are your patients in your community just simply leaving because their care access isn't meeting their needs? And so in our experience, most clinics don't have just one of these challenges. You're usually going to have a combination of several. And so the key really is to identify which one is creating your biggest constraint today. Once you know what that bottleneck is, you're going to be able to start to direct your time and resources towards the changes that are going to actually have the greatest impact. And so that's where we're headed next, to just make sure we're understanding the right problems that we're having.
Great. Thanks for setting that up, Megan. All of those are core issues that a lot of organizations are facing. But as you mentioned about the bottleneck, we as administrators and leaders of practices, we have to understand, what are the bottlenecks, and are they real or are they perceived? And so you'll see in the first little diagram there, the core misdiagnosis, open slots on the schedule look like a demand problem or productivity problem from providers. In our experience, a lot of times, in some cases, that is a problem where providers are not financially motivated. Maybe the compensation plans do not align with allowing them to make more money, which they would like to do. But in a lot of cases, a lot of these organizations have issues on an administrative side, which is causing them to have lower patient volume. So sometimes it's perceived that it's a provider issue, and in reality, it's more administrative. So basically, it could be that scheduling processes are broken. What I'd love for you all to do is kind of think through, and this is not a true polling question, but this is something for you all to think about. There's 3 questions that are on the screen currently, and these are going to be a self-diagnosis for you. So these are really important to think about because this could help guide which direction you start with. So number 1, do you have open slots, but patients are still waiting 7+ days for an appointment? If that's the case, then most likely there's going to be a scheduling structure problem. And you may want to consider some different scheduling structures, and we're going to talk about that. Are providers in your practice regularly finishing 30+ minutes late, or are they charting after hours? That is consistently what we hear across the nation in a lot of practices because of the EHR. Sometimes it's because of throughput. Maybe your medical assistants' rooming protocols need to be changed, and maybe the EHR template or optimizations are needing to be updated. And then finally, is your evaluation and management coding more than 60% level 3 across all providers? So if we know that in the rural communities, you have complex patients, you have older complex patients. So coding accuracy is really important, making sure that you document the work you do, but also code appropriately for what you do as well. So this asking you yourself these questions is really going to help you drive what is real, what is perceived, and then maybe drive you to the next level. This slide is really quick. These are just 3 quick examples of what could be bottlenecks that we see. in organizations where maybe the front desk has a system where they're going to be checking in 5 patients at 9 a.m. instead of staggering those patients. And that causes a huge crush right there in the morning and a big lull. So those patients are going to be unsatisfied. They're going to be waiting on that physician and or provider, and they're going to always be running late. There's providers spending 15 plus minutes charting between patients or taking this home at night. And that is not something that providers really want to do long term. And then finally, we see a lot of times maybe you're trying to control expenses and you have 1 or 2 single phone lines and it's tying up your administrative staff. So you can't reach out to patients. You can't reach out to other providers. So these are just examples of some of the bottlenecks that we're seeing across the nation. So we get a lot of questions related to provider schedules, and we have done quite a few presentations related to this topic specifically. And we always get asked, well, what are some solutions or fixes to that? And so one of the, there's several options for changing your scheduling. And we're going to go through 2 today that we feel are pretty good at helping with no-shows, and we're going to talk about that in a little bit. But your traditional block scheduling, which is your 15-minute blocks, always assumes that every patient is going to arrive on time. Every patient takes exactly the allotted time with the provider, not that they're not going to ask 5 more questions while they're in the exam room with the provider. And then, and nothing unexpected happens. This never happens in the real world. The 15-minute never happens. So we know that this type of scheduling is going to cause bottlenecks. So in this, what this is called is a modified wave scheduling. So instead of having your traditional 15-minute rigid block scheduling, what this does is says at the top of an hour for your patient schedule, you may schedule 2 to 3 patients simultaneously at the same time. And those patients are going to come in maybe at the same time, or they may stagger in, 1, 2, 3, 5 minutes difference. So you're going to room those patients as they come in. And ultimately, there's going to be a good chance that there's going to be a no-show as well. But what this does is it sets it up so that your providers can start seeing those patients, and then you'll be able to have a better flow than having all those patients come at one time. Then at middle of the hour, you may stagger 1 to 2 complex visits, and this may prevent a mid-morning crush. It may give a little breathing room. A lot of times providers are very controlling of their schedule, and they want to make sure that they don't have similar type patients, complex patients all at once. So that's just a reason why you may want to have 1 or 2 complex patients within this hour. And then at the end of the hour, you reserve for an acute walk-in or maybe time for the provider to catch up. So if you do have 2 to 3, 4 patients within that hour, that gives the provider hopefully a little time to catch up and be able to document or at least take notes of what that person did. So again, along with the modified wave scheduling, we suggest that anytime you think about changing your schedules, you really need to do it really methodical, because your providers, your staff are going to be wondering, well, why are we changing this? We've always done it this way. So we always recommend, don't just announce it at a staff meeting and walk away. That's never good. Don't send it out via an email. That's never good. But really, obviously dive into the data. And it may take a little bit more time as administrators, but this really pays off in the end. So for example, in the modified wave scheduling, what we would suggest if you were to switch to this type of scheduling or any scheduling, pull a 2 weeks listing of schedule utilization what percentage of slots were filled, what percent of patients arrived on time. The former slide also did talk about how you grouped patients. In this situation, it says group similar visit types. Some physicians like that, some don't. That's just a recommendation. But basically, you want to audit this action before you initiate any scheduling. So one way to do this is calculate what your no-show cost could be. This is really going to be important for you as leaders and presentation to your administrators to make sure that you're going in the right direction. So calculating your no-show rate is basically take your no-show percentage times your visits per day times your revenue per visit, and then you're going to multiply that by around 250 working days a year, and then that will give you the annual revenue lost based on how many no-shows you have. So really, that's really going to drive, and we're going to show you this in a couple examples with some real numbers, but having that data is really going to be important. And what we also suggest is you don't, when you do change scheduling methodologies, we think that it's best to have a pilot program where you maybe pick one willing provider and try it for 30 days, maybe a little longer, to see is it working? Is it working for the staff? Is it working for the provider? And frame it as you're giving the provider control. They're never waiting for a late patient. Someone is always going to be ready in this situation. So those are just some tips and tricks when you're thinking about changing to maybe it's modified wave, maybe it's the next type that we're going to talk about. A second type of scheduling, which is advanced access, which is same day model. Many of you are going to be probably skeptical of this, but it actually does work, because what happens is a lot of times patients will try to call and get in to see their provider. And then they're saying, well, I'm so sorry, we can't get you in until 20 days from now. That's not really acceptable, because a lot of your patients will go elsewhere, or maybe they don't seek care at all. So in this advanced access same day model, what it does is it leaves a subset of slots open for your same day. So that allows patients who call that need to get in to be seen quicker will have access quicker. And a lot of you are going to say, well, what if we don't have any calls and we don't have anybody show up and fill those? There's going to be some recommendations that we do have if people don't show up in this model, but pretty much about 80% of the time, we do see that patients love this type because they can get in quicker and see their provider. The key metric to watch here, and this is really important, is the third next available appointment. This is the gold standard for measuring true access. And as rural, if your family medicine can't get patients in within 7 business days, then there could be a problem. If it's above 14 days, you're lagging and patients are going to go somewhere else, whether it's urgent care, urban centers. So what we recommend in this, if you do go to advanced access where you do hold appointments on the same day, perhaps you start again with one pilot provider. You start with maybe holding 20% of those slots as same day. And then if it's successful, maybe you expand that to 30% the next month. But continuously reviewing the information to make sure this is the right way for your organization. And it may not be, but it's always an option to think about how can we prevent no-shows and make sure we fill our slots. Again, this is one of the questions we always get across the nation is how do we prevent no-shows from taking place? When we understand why patients miss appointments in rural settings, we stop treating it as a compliance problem, and we try to start treating it as a system design problem. So some ideas to think about. when you're looking at no-shows is, do you text reminders? I know my dentist office texts me probably 4 or 5 times before I arrive, and I love it because it reminds me, because I'm scheduled well in advance. But if you're not doing text reminders, then you really need to start, because that really shows some improvement in making sure patients show for their appointment. Also, make sure if you're doing text reminders, text 72 hours out, text 24 hours out. And for those people that are chronic no-showers, you may want to call them 2 hours before and make sure they're going to show up. And if not, if you have a waiting list, you could perhaps call someone and see if they can get into that slot. We're going to talk about telehealth in just a second, but telehealth is also a proactive way. So if you do have an open slot, utilize telehealth for those people that may be wanting to come in and they're just unable to physically be there. But telehealth is a great option. And then again, if you know that you flag someone that is a constant no-show to your practice, you know Mr. Smith is always gonna say I'm coming, but he never does. You may want to think about double booking, or think of, maybe there's, unfortunately, you may have to dismiss patients based on not able to show for appointments. But the no-show cost calculator in this situation, like I was talking about just a few minutes earlier, is you take the no-show rate times visits per day times revenue per visit, again, 250 days per year. And just as an example, if you had a 10% no-show and then you see 18 visits a day at $175 per visit and 250 days a year, if you improve that, that is almost a $79,000 or lost per provider per year. I apologize. That's the loss per provider. If you were to make a 3% reduction in that, so you go from 10 to 7%, then you could recoup about $24,000 annually per provider. So that's significant dollars. Again, we were talking really briefly about telehealth as a schedule management tool. This is something that a lot of organizations have done since COVID, and we do advocate that this is a great option for patients who have transportation issues. Maybe they're chronic, they can't get out of the house. But just remember, here are some guidelines for telehealth. We always remind organizations to make sure you're watching the state information related to reimbursement for telehealth, as well as the national regulations for reimbursement. So make sure you're staying on top of that. But currently with RHCs and Medicare, you're not getting the full all-inclusive rate when you do the medical telehealth. You bill the G2025, and it's a flat rate. And in 2026, that's $97.53. If you happen to do behavioral health telehealth from your organization, you do actually get paid the all-inclusive rate. And then there's some other items. Originating site only is a different code. Right now it's around $31. Just note too, as an update, that in October of 2026, the G2025 is going to be replaced by individual HCPCS codes with modifiers 93 and 95. So you'll want to make sure you make a note that if you are currently billing telehealth codes, then you need to make sure that your systems are going to be up to date. And then for non-RHCs, you're going to bill standard CPT, HCPCS codes with telehealth modifiers, and then you should verify Medicare rules and payer-specific coverage terms. Basically what this does, it can cause, if you use telehealth, it can cause real-time visit conversion. So if somebody's late, maybe there's another provider that can see that patient that could be virtual. Be proactive on low complexity slots. If someone doesn't really have to come into the office, you can do a quick telehealth visit. obviously volatile block times, last appointment of every day, maybe the time right before lunch, are volatile block times that patients fail to show up. And so it might be a good idea to use telehealth. And then there's always the audio only backup. In rural, we know people may not always have the ability for video capability, but there is audio only backup as well.
Yeah, so we're just gonna pause for a minute here to do another quick poll. So in this instance, we're really thinking about telehealth, not just as a clinical service, but also as an operational tool. So specifically looking at how effectively your clinic is utilizing telehealth as a schedule management tool. Great. So it's always interesting here to see the range of responses. So some of you, are heavily utilizing it, about 6%. And then a lot of you are in that moderately used, rarely used bucket there. So really, wherever you fall in this spectrum, I think the important takeaway is that, telehealth has become one of the most effective tools that you have available for improving access and recovering those appointments that might otherwise be lost. All right, so now we're going to talk a little bit about, patient throughput and panel management. These are two areas where, there's a lot of times a lot of untapped capacity. So we're going to start here with patient throughput and top of license staffing. So this is really one of the biggest capacity challenges we are seeing in rural clinics. So if you just take a minute and you think about, the first few minutes of a typical patient encounter and how much of that time is spent on actual clinical decision making and how much of it is spent on gathering information that could have been collected before the provider even walked in the room. In a lot of the clinics that we work with, you still have providers that are doing medication reconciliation or updating preventive screening information, documenting chief complaints, or collecting information that, a well-trained MA or LPN could handle. And while those tasks only take a few minutes individually, when you multiply that across an entire day, that impact becomes significant. And the goal here isn't to make your staff, your MAs, and your LPNs work harder, but it's really to make sure that everyone is working at the top of their license. So your provider's highest value is really going to be coming from that diagnosis, medical decision making, treatment planning, and patient education. And so that's where we want your provider's time to be spent. Meanwhile, your MAs and your LPNs, they can really play an incredibly important role by preparing the visit before the provider even enters the room. Now, why does this matter? So the financial return is really important. You're going to see here up on the screen that if you're able to save 5 to 7 minutes per encounter and your providers are seeing 18 patients per day, that's going to be roughly 90 to 126 minutes of recovered provider time daily, which is enough for you to add 1 to 2 additional visits per day per provider. Now, if you have even just one additional visit per day at a $175 per visit and multiply that by 250 working days a year, you're going to be seeing roughly $44,000 in additional revenue per provider per year. And so that financial return is really important, but honestly, the benefit goes even beyond the revenue. What we often hear from providers after implementing this type of workflow is that, they're spending less time charting after hours. they're feeling less rushed throughout the day, and they're just able to focus more of their attention on the patient care. So you're not just creating more capacity for your providers, but you're also creating a better work environment and helping to reduce some of, what we hear is causing burnouts amongst these providers. And just kind of a theme throughout the day, if you are thinking about implementing something like this, starting small is always our recommendation. Just picking one provider who's open to trying something new, piloting the process with them, measuring the results, getting their feedback, and then deciding whether to expand can be really helpful. Because when your providers are experiencing this firsthand, they can become some of the strongest advocates for the change.
Perfect. That's really good information, Megan. So she just talked about patient throughput on top of licensing. The other thing that organizations and administrators and clinic managers need to think about is panel management. Because if you do have open slots during the day, you don't necessarily obviously want your providers to sit idle. You need your medical assistants to be busy because you do have a lot of fixed costs related to that. So in most rural practices, you're going to have some capacity. So what we suggest is look at your patient panel. You're going to probably have anywhere between, and this is your numbers may be way more than what I'm just going to quote, but in any given patient panel for a provider, there's going to be anywhere from 80 to 150 patients that have chronic conditions that are overdue for a visit. Maybe they haven't been there for 16 to 24 months, but there's a reason why they need to come back. They may, there's a way to help with this. And so how to run a gap in care report basically is looking at your panel is you pull a gap in care report from your EHR. What we see, Epic, Athena, NextGen, a lot of these have something that is built in. I've even seen it in my career where we have to pull this information manually. If you know someone has a chronic condition, like step 2, if you filter for patients that have been seen in the last 18 months with diabetes, hypertension, COPD, who have not had a visit in 6+ months, they probably need to come in and see their provider just to make sure that everything is okay for quality of care. Not just because you want another visit, but it's for care quality. And so what you would do in this situation is if you're able to look at your panel and you identify these chronic care patients that have not been seen within this period of time, you can assign one of your medical assistants to help call these patients, to have them help schedule and get them in so that they can get the care that they need. Again, with the return on investment with that, if you do the math, a lot of rural panel sizes are a little smaller than urban. We see anywhere from 1,200 to 1,500 patients in a panel. That could be slightly higher for some providers. And in this situation, if you had 3 additional scheduled visits per week, and assuming 48 weeks per year at $175 a visit, that could mean $25,000 in additional revenue by looking at your panel and looking at those patients that, due to chronic care, need to come in and be seen. Again, frame it different for your providers because they're not going to look at it from a revenue perspective. They just need to know that we're taking care of the patient and it's in their best interest to see the patient.
All right, we're going to do another quick check-in here, a poll. So, of the strategies we've covered so far, scheduling, no-show reduction, telehealth, top-of-licensing staffing, panel management, how would you describe your clinic's current state? All right, great. So it looks like a lot of you all who are responding are in that, we've tried a few but haven't fully committed, or we know we need to make the changes but haven't started. And I'll just say, you all are not alone if you answered that way. Or even if this is new territory and you're starting from scratch, that's very typical and what we are hearing. Um, so you just don't feel like you're alone in that.
Perfect. And we do have a lot of material today. So we are going to probably speed up some of this. You will get the slide deck, which is going to be really important. And Megan and I are always willing to talk with anyone on this presentation or anyone you know about any of the content. But what this next item shows is really 6 really important metrics that organizations need to think about for their practices. Hospital administrators a lot of times think about the hospital, and then sometimes clinics are the last to be, we know we're losing money on the clinics, but we don't know what to do. These 6 metrics are going to help drive that. And for instance, we talked about no-show rate. In rural areas, you want to see if hopefully that's less than 8%. Your third next available appointment, which we said was gold standard, you want to make sure you can get patients in with less than or equal to 7 days. If it's over that, you need to dive in and see what's going on. Visits per day per provider, 16 to 20 is the target. There are many organizations where we go on site and we actually do interviews, and we ask the providers specifically, how many patients per day do you see? And they say, oh, we see 16 to 20. But in reality, when we actually get the data, they're seeing 10 to 12. So there has to be some changes to help them from an administrative burden. Most likely it's a process issue. Work RVUs is something that we recommend you look at. Even if you don't pay on work RVUs, definitely look at this, and we can benchmark this, or you can benchmark it to industry standard. We also, I'm not a certified coder by any means, but please also look at your E&M levels. This one specifically says level 4, but you really want to make sure that you're looking at your coding compliance and make sure a certified coder is guiding your providers to code appropriately for the work that they are doing. And then finally, a lot of times claim management or claim denial rates is one of the last things that you think about. You get the denial report and you just don't have enough people to work those denials. Insurances are going to deny those on purpose a lot of times, and then it's up to you to try to collect, and insurance companies know that it's going to be rare that we fight those. Again, not going to belabor this, but coding accuracy is something that we do recommend getting a certified coder into your organization. If you don't have certified coders or some that may need education, highly recommend reaching out and getting that education for everyone in your organization that is part of the revenue cycle and billing.
All right, so we're going to talk about 2 quick changes to some RHC updates. So for years, there were productivity standards, which created an external benchmark that your organization had to monitor. And these provided a clear expectation for you all. And now that requirement has been eliminated for about 1.5 years now. And so this is really important because your organization now has a little bit more freedom to design schedules, staffing models, workflows that makes sense for your local community. But there's also a little bit of a risk because we've been seeing some organizations unintentionally not paying as much attention to productivity altogether. And so, the reality though is that provider productivity still matters, your access still matters, financial sustainability still matters for you all. So you all now need to get to a point where you are designing or defining success for yourselves. One thing that we oftentimes ask leadership teams when we meet with them is if we interviewed their providers, their clinic manager, and their executive team separately, would they all describe productivity expectations the same way? And a lot of times the answer is no. And so this change here just creates an opportunity for you all to really establish clear internal expectations, some meaningful metrics, and a shared understanding of what success looks like in your clinic.
Perfect. And the other change that we want to make sure that everybody has adjusted to is if you are doing chronic care management, principal care management, remote patient monitoring, the for RHCs, the billing was to bill the G0511 code. However, that was eliminated effective July 1st of 2025. So it is now asked that you bill the specific code if you're doing chronic care management. This is really beneficial for a lot of rural health clinics to be doing this work if you have the staff to do it. But we just wanted to make sure that you understand the new billing requirements. Again, we've talked a lot so far about different types of strategies. So no-show reduction, top of license throughput, panel management, maybe chronic care management outreach, and then coding accuracy. What this document and this slide is saying is that for a 3-provider organization, if you were to just look at even 3 of these items and improve any of these that you currently maybe are lagging in, you could see potentially a conservative impact, again, a 3-provider clinic of about $330,000. That's a lot of money per year. If you're lagging more greater than that, then you could see up to a $600,000 improvement, which is amazing. Again, we talked a little bit about this, but when you're getting buy-in with all these changes that you potentially want to make, and again, don't make them all at one time, but this is really a nice quote from someone from the MGMA annual conference. You can't mandate buy-in, but you can only earn it. One data point, one pilot, one honest conversation at a time. And you're going to have different audiences when you're rolling this out. So you're going to have leadership. Maybe it's the CEO of the organization. You're going to have providers, front desk individuals, and schedulers. And then you're going to have clinical staff. Each of these audience members are going to need a different type of why are we doing this and a different type of conversation. It's going to take a little bit of time, but I promise it will work out in the end when you do have the whys behind changes are occurring.
Yeah, that's a great point, Shad. People want to understand, why change is happening and how the success is going to be measured, and also just how it's going to affect their daily work and if they're going to be supported throughout this process change. But that's why leading with data is so important, because when you walk into a meeting and say, we need to change our scheduling process, people are going to naturally become defensive. But when you say, okay, our schedule utilization is 74%, our no-show rate is 11%, and it's costing us X dollars each year, your conversation is going to be different. Because you're going to be talking more about a shared problem instead of a proposed solution. And then I think just one more important lesson that we've learned is that people closest to the work are often going to have the best insights about implementation. So this is also an opportunity to engage your front desk staff, your MAs, your nurses, and providers, because they're going to be able to identify the barriers that they're experiencing and also, offer some opportunities that leadership may never see. So involving those parties, early and asking them questions and listening to them can also be a really helpful tactic.
Perfect. Thanks, Megan. Finally, implementation roadmap. is always something to think about. Everything that we talked about today, you all maybe having ideas about how you can implement one, two, maybe even three of those within your practice. But it's really important to make sure that you phase it out and you make sure that you do it in a methodical way. Maybe you have a strategy, a strategic plan on how to do that. This basically outlines that we suggest, your first several weeks, you're going to diagnose kind of what we talked about earlier. What are our issues? Do we have coding problems? Do we have a lot of no-shows? Identify those problems, and then you can decide in the next several weeks, what do we want to launch? Do we want to launch the text reminders if we don't have that today, or do we want to set it up at a different cadence? Do we want to train the medical assistants on rooming protocols so that could maybe help with throughput? And then, maybe even think about telehealth items. We say this to say that all of this is not going to happen overnight. All of this is going to have to be strategic, and you're going to have to communicate, over communicate, and then have a good plan. I will say that in my career, we have tried things and it has failed. Doesn't mean you did wrong. It just means that we may need to recoup and regroup and go back to something else. So it's always worth trying things. Again, it's going to take months to expand the programs that you're trying. When you start with one or two providers and then you expand it to others within the system, and then it's going to take time to sustain it. You're going to have to really drill it into everybody's workflow, that this is really the way we need to operate.
Yeah, so just as we wrap up here, we really just want to leave you with a few things. And so first is just, diagnose before you prescribe. Don't just jump to the solutions before you're understanding the process or the problem. Second, it's important to start small. So you don't need to implement everything that we talked about here today, but just, pick one opportunity that you think is going to be the most impactful for you, measure it, and then build from there. And then the third is really just, leading with data, whether you're talking to providers, staff, leadership, or your board, the data is what creates the credibility. And the most successful clinics we work with aren't necessarily the biggest or the best funded, but they're the ones that are consistently identifying problems, measuring the results, and then continuing to improve. So those are just those three things. Just continue to, remember and keep top of mind.
Exactly. And then this is why I wanted to end with the same quote that I started with. Again, you don't have to have the biggest buildings, the best buildings, or the biggest budgets, but if you perform well, you're going to do well financially and have a great outcome for your patients and your team.
Right.
All right.
Thank you, Shad and Megan, for sharing these practical strategies that rural organizations can use to strengthen practice operations and improve patient access. Unfortunately, we don't have time for Q&A, but if you have any questions, there's a bunch that are in there now. And if you haven't added your question, do that now. We will be able to answer, Shad and Megan will be able to answer them via email. So please go ahead and do that. As a reminder, when you exit today's session, you're going to receive a brief survey pop-up. The feedback helps us to continue shaping future conference programming. It'll take you less than 1 minute to complete. We really appreciate that you fill that out. And then if you're joining our next session, please return to the conference lobby and click into that session from the agenda, and we're going to begin at the top of the hour.